evening. Welcome to the Myasthenia Gravis Association virtual monthly meetup. We're so glad you're here. I'm Catherine Clemens, the Community Program Coordinator for the Myasthenia Gravis Association. If you're new to the MGA, we encourage you to visit our website at www.mgakc.org to explore our programs, resources, and upcoming events. If you're newly diagnosed, please email us at info@mgakc.org or request a new patient packet. We're here to support you on your journey. Also, don't forget to register for our upcoming Triple Crown Showdown 5K, and you can get more information at www.mga5k.com. We offer both in-person and virtual participation options, as well as those diagnosed with myasthenia gravis can register for free. Lastly, after tonight's session, you'll receive a brief survey. This is a great way to share feedback and check out our upcoming virtual programs. We're thrilled to welcome Dr. Christina Kelly, a doctor of physical therapy at the University of Missouri, Columbia. Dr. Kelly's research focuses on understanding and treating motor dysfunction and fatigue in individuals aging with neuromuscular conditions. Through her research, she aims to develop function-preserving and restorative interventions while also tailoring approaches for those with neuromuscular disorders. Chris is currently a sub-investigator on several industry-sponsored clinical trials at University of Missouri, as well as principal investigator on a pilot exercise study at MG. Please join us in welcoming Dr. Christina Kelly.
Thank you so much, Allison. I'm just going to go ahead and share my screen so that everyone can see. Does that show up for you there?
Yep, you got it.
Perfect. All right. Well, welcome everyone. Thanks for joining me this evening, and thank you to the MGA for inviting me to give this talk. I'm really excited to share more about this topic with you, physical therapy after thymectomy. So just to get us started, here are a few objectives that I have for this evening. I'm hoping to provide you with context for why physical therapy may be necessary after thymectomy. I like to describe how physical therapy can be helpful if you have residual neuromuscular skeletal issues after surgery. And I also want to arm you with information so you can advocate for yourself with your team of healthcare providers. So during the presentation, we'll be going over briefly where the thymus is, just to make sure we're all on the same page. I'll be giving an overview of some of the different thymectomy procedures and some of the related anatomy, talking about potential neuromusculoskeletal impacts of the surgery, tissue healing and physical therapy approaches to address post-thymectomy issues, and then a little bit to finish off about prehab and the role it has in potentially reducing post-thymectomy complications. So to get started, before I start, actually, I wanted to say I'm going to be showing a lot of drawings of different anatomy and some of the surgical procedures, and I will be showing a few real patient pictures, which are a little more graphic, and so I will be giving kind of a warning when I'm about to show a real person picture, so that if you don't want to look, you don't have to, all right? So where is the thymus? The thymus is this gland, this gland right here. It's located in front of the heart. You can see it again right here. And it's located behind the sternum, which is right in front here. It's cut out in this picture. And here, what we've had done is remove the rib cage so you can see into the side. But you can start to appreciate that there are bones and muscles here that are kind of over where the thymus is located. And you can see again here, these bones and muscles. And so you can sort of start to appreciate how in order to access the thymus for a thymectomy, you may be disrupting some of the musculoskeletal structures that cover where the thymus is. All right, so the types of thymectomy that we'll be discussing tonight are video-assisted and robot-assisted. This is in an order of least invasive to most invasive. So the video-assisted and robot-assisted are the least invasive. And I've lumped these together because for the purposes of our conversation tonight, they're sort of similar enough for us to talk about together, followed by the transcervical and the transsternal. And just a little disclaimer, as I already said, I'm a physical therapist, so I am not a surgeon. I'm going to present generally about these procedures based on available literature and video resources, but you should always ask your surgeon about the details of your specific procedure to be able to make the most informed decisions about your care. Okay, so starting with video-assisted and robot-assisted thymectomy. Basically, for these two types of procedures, there are essentially three tools that are inserted through the rib cage and into the chest cavity to access the thymus. There are some different ways that this can be done, but I'll kind of be focusing on two tonight. Primarily, I'll be talking about what's called the mid-axillary approach, and I'll also touch a little bit on what's called the subxiphoid approach. Okay, so the first pictures I'm going to show for the mid-axillary approach, these are actually real patient pictures, and they're going to show someone on the operating table before the surgery is started and what the setup looks like. Okay, so you can see here that the spine is a little extended here. So they place something kind of underneath your chest to kind of expose that chest and get it up a little bit. And you can also kind of appreciate here where the arm can be in different locations. So it might be down, it might be up. I've seen some pictures where it's like across a little bit. And so that can probably vary a little from surgeon to surgeon, but it has some implications for how it affects the structure of the shoulder, whether it's compressing certain structures or stretching certain structures. So the next picture I'm going to show is also a real person picture, and it's going to show where the tools get inserted. Okay. So you can see, so on this mid-axillary approach, so mid-axillary basically means like down the side of the axilla. So the axilla is the armpit area. And so they're inserting the tools kind of down along the side of that area there. So you can see these tools right here. And also one that appears to be a little more anterior. And from what I can tell, surgeons may have slightly different places where they insert the tools. So that would again be something that you may want to ask your surgeon about, like where they might be inserting the tools. So what do these tools have to go through to actually get into the chest cavity? So for the mid-axillary approach, we're going to be looking at this side, the side of your body right here, right? And the tools are probably going to be inserted somewhere in this region here. So there's kind of a handful of muscles that could be affected by that. You've got this really big muscle right here called the latissimus dorsi that helps to move your arm down by your side. You also have this muscle right here, which is called the serratus anterior, and that helps to move your shoulder blade. We also have this external oblique here, which helps with some side bending. All right, so all of these muscles could potentially be places where tools have to go through for this type of procedure. Okay. Additionally, again, depending on where the tools get placed, it may have to go through part of the pectoralis muscles. So which you have a pectoralis major, which is kind of on top, and then the pec minor, which is underneath the pec major. Okay. So that's a little variable depending on what type, like where the surgeon's inserting, but the one group of muscles that you sort of can't avoid going through at all in this approach are called the intercostal muscles, okay? So just to orient you, this is your sternum here, so that's your sternum here. We're looking at this half of the rib cage kind of over here, okay? So the pectoralis major muscle is gone, it's been kind of taken away. We've got the pec minor muscle here and the serratus anterior muscle here. And if you look at this kind of excerpt over here, you can see that there's several layers of muscle in between each of your ribs. Okay, so you've got 12 ribs, you've got these ribs here, and each in between each rib are these sets of muscles, and that is where the surgeon would insert the tool in that space in order to access inside the cavity. Okay, so that overall is all the tissues that potentially could be affected by a mid-axillary approach. As I mentioned, I was going to talk a little bit about the subxiphoid approach, and the subxiphoid approach is basically underneath the sternum. So the xiphoid is this little tip down here at the bottom of your sternum. And so what they do is they make an incision here and go in underneath the sternum up to access the thymus underneath your sternum up here, okay? So, but what that means is you can appreciate here is you've got your rectus abdominis muscles. This is one of your main abdominal muscles down the middle, attaches right up in through here. So they would have to get through this rectus abdominis muscle in order to get up underneath the sternum. Okay, so summary, in the mid-axillary approach, you have some lateral chest muscles and some anterior chest muscles that may be affected depending on where the tools are inserted. The tools would have to go through the intercostal muscles. If they go through the subxiphoid approach, they would also go through the rectus abdominis muscle. And then there's also those positional considerations that I alluded to at the beginning, where if you've got your arm over your head or down by your side, you're looking at whether or not you have the range of motion to tolerate that. And then also that extension in your spine when they're going to prop you up, it's really going to open your chest up. And so if your posture is a little more head forward, chest forward, that could be a place where when you wake up from the surgery, you're having a little bit of trouble because they've forced you into that position for the surgery. Part of that is also then with the shoulder, there's lots of nerves that go through here. And I'm going to show you a picture of that actually in the next section. But there's a lot of nerves that go through here. So if any of these positions have kind of compressed on the nerves or have kind of pinched down on them, that could also cause some issues. So the next approach I'm going to talk about is the transcervical thymectomy, okay? And for this approach, they're going to make a small incision right at the top of the sternum, okay? So they're going to go in above as opposed to the side or below like I just talked about. So I'm going to start off by showing you a drawing of the positioning, and I think you'll probably see some of the kind of things we're going to talk about right away here, okay? So what happens here is, again, they're going to prop you up underneath your upper shoulders, and you're going to extend your neck way back here and then put a pillow under it again here. This incision is going to be right here, and what's going to happen is you're going to get a pretty good stretch of all these muscles on the front of your neck here. And then potentially you're also going to get some closing of your cervical spine as it bends back a little bit. And there are all these nerves that come out of your cervical spine that then come down, come through your shoulder and basically make connections with all the muscles in your arms and your chest and your back. Okay, so any of these could get kind of pinched down on while you're in this position. These surgeries could take about 2 to 4 hours. So if you think about being in this position for that long, that could cause some post-surgical issues. Now, when they make the incision would be right around here. They're going to cut through a sheet of muscle here called the platysma, which is mostly involved in facial expressions of the lower mouth area and the chin. And then they will have to move aside some muscles to access the thymus, because you can see here's the thymus right here. There's this muscle called the sternocleidomastoid sitting right in front of it. So they would kind of need to use some tools to pull this to the side so that they can gain access to the upper part of the thymus here. And then you may also be appreciating the fact that then the rest of the thymus sits underneath the sternum right here, okay? So in order to create space to get the tools in, to get the rest of the thymus, basically they have to elevate the sternum. And I'm going to show you a picture of that, and this is a real person picture again. And basically, here's the incision. They put a hook underneath the sternum here, and there's a pulley system above the surgical field. And they use the pulley system to pull the sternum and the rib cage up away from where the thymus is to give space for the tools to go in there. All right, and so when that happens, you're going to be getting a lot of stretch in some of the joints here, where your clavicle meets your sternum, where your ribs meet your sternum. And so again, depending on how much mobility you have in these joints before surgery, may or may not cause some discomfort to you after the surgery. So to sum that up, positionally, we're going to have some hyperextension of the neck. And depending on your neck range of motion, you might experience some overstretching of the anterior neck muscles. You might get some compression in the joints in your spine of your neck, and also some of the nerves that come out of there. There's then the incision through that sheet muscle in the front of your neck, some retraction of some muscles, and then that elevation of the sternum that may affect some of the joints there, as well as stretching some of the muscles across your chest. And you will go into a little bit more extension in your upper back. And so some of those joints there might get a little bit of extra stress to them as well. All right. So the last one we're going to talk about is transsternal thymectomy. This is the most invasive because they have to split that sternum down the center in order to open the chest cavity to see the thymus right above the heart there. From what I've read and learned, this typically is not the way, like the most common one these days. It used to be. And so if you had a thymectomy, years and years and years ago, this may have been the only approach that they had, but technology has come a long way since then. So they do have many more minimally invasive options. The reason they might do a transsternal thymectomy these days is, for example, if you have a thymoma associated with your myasthenia gravis condition, and if the thymoma is large and they're not able to kind of visualize it well with the less minimally invasive approaches, or if there's tissue in place, we're all individual. You might have tissue in place that they're not expecting you to have thymic tissue. And it's really important for them to be able to get all the tissue out, because any tissue that remains in there could still cause you to have MG symptoms. So they really want to make sure they get it all. So if they go in a minimally invasive approach and they find that they can't get all the tissue, they may have to convert to a more transsternal approach to make sure that you get the best results from the surgery. So what happens, this next one is a drawing. All right, so another thing they can do is, instead of doing it all the way down the center, oop, that's my bad, I didn't mean to do that. They can do a partial sternotomy and just expose where the thymoma or where the thymus is. So that wouldn't involve splitting all the way down. But basically, if they have to do the one where they go all the way down, once they do that, they use tools to kind of pull the chest open to show the heart. And that's what the next picture is. So again, it's a real person picture, but you're only really going to see the chest cavity here. All right. And what I want you to appreciate is that there are tools on the sides here that are holding that open. Because as you can kind of see here, the heart is here. All right. And that's what this is here. And so in order to get at that thymoma, they need to create a much bigger hole there. And what that will do is it will compress a lot of these joints where the ribs meet the sternum, where the clavicle meets the sternum. It's going to stretch some of these neck muscles. It may compress some of the chest muscles and compress some of the back joints as well, because everything's just kind of getting jostled open much further than any of us are used to. So after the surgery, they do have to sew this all back up again. So you would have multiple layers of sutures. Okay, so there'd be wire holding the bone together, and then sutures holding the top of the bone together, sutures holding the subcutaneous tissue, and then sutures over the top of the skin. So that's many layers of suture. And I'm going to show you, and the next picture is just a closed person with the scar. So this is what it might look like after the surgery. Okay, that's kind of T scar where they open here and then come down before they split. So to sum up, there's a lot of disruption of the skin and the soft tissue right above the sternum. Obviously, the sternum itself. You're going to have displacement of many tissues during retraction of the sternum as they open the chest, including joints and muscles in the chest wall and the neck. And I also should have mentioned, if they have to go all the way down toward that xiphoid process at the bottom, as I mentioned, that's where the rectus abdominis attaches. And so there may be some disruption of muscle down there as well. And you're going to have a beautiful scar at the end. So that sums up the surgical procedures. So we're going to shift gears a little bit now, and I'm going to talk a little bit about tissue healing. Okay. So normal tissue healing, there's stages to it. The first 7 days is more of an inflammatory stage. It's when a lot of blood is circulating to the area and trying to make sure it's getting all the nutrients that it needs to improve and heal. You then have this like 1 to 6 weeks or 2 to 6 weeks, a proliferative phase. And this is when scar tissue is forming and maturing, okay? And this is a really important time to give gentle stresses to the tissues according to whatever your physician tells you you are or not allowed to do during that phase. And that would depend a lot on the type of surgery that you had. But you want to start giving light, very light stresses to the tissue so that they can begin to align in the appropriate way and heal. So that then when you get to week 6 to 8, you can start to see some muscle strengthening occurring, some normal muscle tissue coming back. And that's when a lot of the remodeling happens. And that can happen starting at 6 weeks, but then moving forward. And in a perfect world, this all happens naturally as you follow your surgeon's post-op protocol, but that's not always the case. And sometimes you can end up with persistent scar tissue. And so what happens with scar tissue is, you have, these are your healthy pre-injury, pre-surgery fibers. Your muscle fibers, they're all nicely aligned here. This is a nerve that's kind of diving through the muscle fibers. It's free of the muscle. You've got little nerve branches going out and innervating the muscle. And then when it's injured or when it's disrupted, you get damage to that. And so these damaged fibers, they sort of start to heal. But instead of continuing along a normal path, you can get scar tissue, which, as you can see here, is really disorganized. Instead of being aligned with the muscle tissue, it's all kind of like wonky. All right. And that means that the muscle can't contract as well because this tissue isn't aligned with the way the fibers are meant to be. And if you have scar tissue that remains, it can interfere with the ability to contract. It can interfere with the ability of these nerves to move in the fiber. And that can also cause a lot of discomfort and issues with movement. So the same thing can happen with ligaments. Ligaments join a bone to a bone, so at a joint, versus muscles, you've got joined to a bone by a tendon. So the same thing can happen to ligaments that can happen to tendons or muscles, where you get stretching or little tears. I wouldn't expect any of these surgeries to result in complete tears, although I don't know that it can't happen, but I would expect that any stretching of the ligaments that happens would be more in these kind of more mild sprain type of situations. But then what happens when you get excessive stretch is that when it heals, you can get scar tissue that, again, you get adhesions. These muscles don't move as well across each other or next to each other, and nerves can get stuck in there and not move very well. And that can create a lot of tension in the nerves, which basically feels like a muscle you can never stretch. Because you're just like pulling on the nerve essentially as it's trapped where it is. And just to give you a more real muscle example, this is what normal tissue looks like, and this is what scarred tissue looks like. And you can see it's not nearly as organized in its microstructure. All right. So with all of that we've just talked about, I hope you can see how there are many potential neuromuscular skeletal impacts that can happen after surgery. In addition to scar tissue and adhesions, which I just sort of talked about, this can lead to stiffness in joints and muscles, nerve entrapment, muscle weakness, and all of this can kind of play into postural dysfunction and movement dysfunction. But even if you don't have any of these things up here, there are things that we can do without even knowing it after a surgery that can lead to postural dysfunction and movement dysfunction. For example, if you know you've just had a surgery, you might kind of subconsciously start protecting yourself. And so you start kind of cradling yourself or moving in different ways or positioning in different ways because you're trying to protect the area that you know you just had surgery. And if you do that over and over and over again, it'll change the way that you move, and that can also lead to postural and movement dysfunction. And that can occur in any of the places that we've talked about, depending on the surgery that you've gotten. So arm or shoulder, neck, chest, spine, trunk. But the good news is that tissues will heal in the direction of forces placed on them. And PT can help you place the right forces on the right tissues to facilitate healing and get you moving and feeling better again. So let's talk briefly about some of the many physical therapy approaches that could help you after a thymectomy. Okay, so we've got many different ways to do soft tissue mobilization. Scar mobilization. You can take a superficial scar like the one that I showed down the chest, but it could be any scar anywhere. And you basically gently move the scar in different directions to try to get the skin to align with the tissues underneath it. And this is really important because even though that scar is more superficial than anything embedded within the muscle, you can get kind of adhesions to that tissue underneath, and then it almost looks like a pucker on your skin where it's like things don't really move, and it can restrict the way that you are able to move, and it can be quite painful. And so doing early scar mobilization will allow those superficial tissues to slide across each other like they're supposed to, and that can be really helpful for healing. You can have instrumented assisted soft tissue mobilization. There's any number of metal tools, there's other types of tools contoured in different ways, different sizes, different shapes that can be used to try to help to break up some of the scar tissue within muscle. Some of this can also just be done with the hands, but a lot of times the tools are a nice way to kind of create a more uniform feel of that soft tissue mobilization across the muscle surface. There's also something called active release. Active release is basically where when there's a tight spot, whether it's an adhesion or a scar, or you just have like a giant knot or something like that, that you basically, the PT will put pressure on it and then have you move around, move the joint around, move the arm around. So for example, this person is getting pressure on in their axilla there on the inside of the armpit, and then they're probably moving their arm up and down here to kind of release that adhesion or scar or just knot. And same thing over here. It's, you know, the person's holding down here and they're moving their neck away, trying to get things moving a little bit better there. And then of course there's good old fashioned stretching, and there's nothing wrong with stretching, and there's lots of great stretches that can be done to kind of build on a lot of these other more technical mobilization techniques. So then there's nerve gliding. So as I mentioned, nerves can get pinched at the neck, they can get pinched under other bony structures, they can get pinched in muscles, and they're continuous. They come out of the spine and they make their way down, they merge together, then they branch again. And so any nerve can get stuck at any place along its route. And so nerve gliding, basically the idea is that you put slack on one end of the nerve route and tension on the other end, and it kind of pulls the nerve through its route. And then you do the same thing in the other direction. We also call nerve gliding nerve flossing, because if you think about the way that you floss your teeth and you kind of floss in and out, you're kind of doing the same thing with the nerve going through its muscle route, wherever that is. And so when we know where the nerve goes, we can create certain movements that move the nerve. So this is an ulnar nerve glide, and this is a radial nerve glide, and this is a median nerve glide. So there's lots of other different types of nerve glides. There's also nerve glides for the lower extremity, for like your sciatic nerve. Lots of different nerve glides that you can do to try to get those nerves moving through the muscles and through their sheaths more smoothly. So then we've got joint mobilization. So physical therapists learn all the different shapes of all the bones in the body and how they meet up with each other and how they move against each other. And when that is dysfunctional, we can use our hands, we can use belts and straps to help those joints start to move again. So, this person is getting some mobilizations in their upper spine, their upper cervical spine here, versus, these are examples of, a person having their hip mobilized. This is an ankle mobilization. This is a shoulder mobilization. There's any number of joint mobilization techniques that therapists have in their toolbox and can use to help get some of your stiff joints moving again. I'm not going to go into too much about targeted strengthening exercises. Again, this is probably something you're all pretty familiar with, that for any given muscle group, we can give you exercises that target strengthening that muscle group. And all of these things, the soft tissue mobilization, nerve gliding, joint mobilization, strengthening exercises, they all play into they can all play into postural re-education, right? So if after surgery you have a posture that kind of is not helping you move very well, and maybe your posture wasn't great before surgery and it's something that needs to be worked on, all of these things can be pulled together to help improve your posture. And the reason that's so important is because this kind of ideal postural alignment, you actually have to do the least amount of work to keep this alignment. When you're in this alignment, all your joints and all your muscles are kind of in that spot where they don't have to work very hard. Versus when you are out of alignment, this person here, gravity's pulling down on his head, which means these muscles back here have to work really hard. And when gravity's pulling down here, it means that these muscles have to work really hard. And, so every time you're kind of out of alignment, you're creating a situation when one muscle group has to work a lot harder to try to keep you upright. So postural re-education may be something that you end up wanting to do after surgery, especially if you've been in a position during surgery that you've kind of been forced into that you're not used to. Getting used to kind of that ideal posture can be really great. And last but not least, breathing exercises. So your lungs are underneath those ribs and around your heart, right? And so when you are trying to breathe, if your chest wall is stiff, your lungs can't inflate as well as they could, and this can limit how well you breathe. After surgery, we can have you do diaphragmatic breathing, which is nice deep belly breathing. That can help to strengthen your diaphragm as well as help your rib cage move. Incentive spirometry can help some of those intercostal muscles heal. Those are the muscles that kind of control breathing in and breathing out. And aerobic exercise is obviously a great natural way to kind of get your lungs going, get your breathing going. All right, so I've really focused on the surgery-related things, but I don't want you to forget that physical therapy can be great for just your general myasthenia gravis management. And especially after you've had a thymectomy, you should take advantage of the early improvement of MG symptoms and address weakness, fatigue, and any general deconditioning that you've experienced, because it's just been really hard to do a lot of activity or a lot of exercise with kind of those exacerbated symptoms. So for MG, full body strengthening programs are great. I would always always say don't just focus on your weaker muscles, the ones that are more affected by MG, like your proximal muscles, but also focus on the more distal ones because they can kind of help compensate when those proximal ones feel a little weaker on those days when maybe you're having good days versus bad days. Make sure you take plenty of rest though. Alternate the muscle groups that you work on so you don't overdo it, and definitely don't exercise to failure. You always want to be able to complete the exercise the way that you intend to. Same thing with aerobic exercise, moderate intensity. You can use a talk test, which basically while you're doing the exercise, you should be able to continue to speak while you're exercising. If you're gasping for air, you can only get a word or two out, you're probably vigorous, and that's probably too much. You don't need to do that much. You can bring it back down to moderate. And really just the rule of thumb, start low and slow and just build as tolerated. All right, so to finish up here, I'm going to talk briefly about prehabilitation. I know that the title of this is PT after thymectomy, but I did want to put a plug in for the idea of prehabilitation. And just so that you know, any of these techniques would be great things to do before you have surgery. The idea being that if you can address some of the things that are going to potentially be an issue during the surgery, then that's maybe one less thing you have to deal with afterward. If you know you're going to have a transcervical approach and you know that you don't have good neck mobility, you can go to PT and have someone work with you on your neck mobility so that when you're in this position for 2 to 4 hours, your neck is ready for that, or it's more used to that. So that in general is something you can do. But I also wanted to highlight actually 2 research studies that that talk a little bit about other benefits of prehab. So these 2 studies, one used respiratory muscle training and aerobic exercise, and the other one used a more comprehensive approach. So in this first one, they only did 5 days of prehabilitation. It was a pretty short prehab stint. And like I said, it was aerobic exercise and respiratory therapy, and there was no physical therapy after. So they really were just looking at like, what is the effect of this really short prehab? This other one, the benefits of comprehensive rehab after thymectomy, they actually did 3 months of prehabilitation, 3 times a week in person, 2 times a week at home, and 2 days of rest. And then they did aerobic, strengthening, and respiratory therapy. So a little more comprehensive, but I think the most important part is it was a much longer period of time. In this study, they did show improvements in pulmonary function tests and forced vital capacity and in just the ability to get back to daily life, but they didn't show improvements in things like your ability to walk further and things like that. However, I'm going to show some of the results of this study. There were many immediate post-surgical benefits that the people who did the prehab had a lower rate of ICU use. They had shorter hospital stays. They were less likely to have a post-operative myasthenic crisis. They were less likely to have lung atelectasis, which is basically when the tubes in the lung collapse on themselves, and fewer incidences of pneumonia. And all of these things, if they do happen, can kind of set you back in your recovery. And the studies showed that the group that did the prehab fared much better in all of these metrics than the people who didn't do prehab. And then for longer term benefits, the people who did the prehab and then also did the post-surgical rehabilitation had quicker and more significant recovery in MG-related measurements at 1, 2, and 3 months. So walking, breathing, grip strength, fatigue, quality of life, and overall MG symptoms were all statistically significantly better in the group that did the prehab and rehab than in the control group that did not do those things. They also had more instances of full MG remission at 3 years. So it's only 1 study, but this is pretty convincing in my opinion, that something like this could be really beneficial to do. So not just doing the rehab afterward, which is definitely a huge help. And even if you didn't get to do prehab, rehab is still extremely important and can be very helpful. But if you have the opportunity to do prehab beforehand and then also do the rehab afterward, I think that gives you the best chances of having the most optimal outcomes. Because in general, prehab creates physical reserves. If you're already better off before the surgery, then after the surgery, everyone declines after surgery. It's really hard on your body. You're gonna come down a little bit. But if you're already at a higher level, then that decline isn't as impactful as if you were at a lower level and trying to climb your way back up again. So just remember that you get physical reserves with prehab, and that is what kind of sets you up to succeed in the rehab afterward. All right, so just to wrap things up here, each type of thymectomy procedure requires some disruption of overlying musculoskeletal structures. And while spontaneous healing can occur, incomplete healing can cause discomfort and ongoing movement dysfunction. There's a lot of different physical therapy approaches that can address these issues, and it can also be useful for MG management. And just a plug for participation in prehab and rehab as the optimal strategy to maximize your positive outcomes of thymectomy. So that's all I have for you, and I would welcome any questions you have at this time.
Yes, thank you so much. The Q&A or chat, you can put some questions in there if you have any. But I mean, I learned so much, so thank you so much for that presentation.
My
We'll
pleasure.
give them a few minutes if there
Sure.
are questions. We'll see if they come in. Someone asked if you could provide a copy of the presentation. It is being recorded, so there will be the recording of the presentation on our YouTube, usually within 24 hours, or at least within the week. So our presentation will be up.
But I'm happy to provide a copy as well. And I don't know, I can either give it to you, Allison, to post somewhere, or if not, people can also reach out to me directly and get it. I'm more than happy to share it. Yeah.
Yeah, either way, you can shoot me an email and we can send
Okay.
it off to our attendees
Great.
that are present. So
Sounds perfect.
perfect. Any other questions? I honestly feel it's kind of hard to ask questions because it was great. So I appreciate it so much. No.
It was a lot of information, like a lot of information. I know it's really hard to digest, and definitely like when the presentation gets sent to you all, my email address is on the last slide. So if you don't have questions now, but you end up having questions, please don't hesitate to reach out to me. I actually would love to hear from you and help you in any way that I can.
Oh, awesome. Thank you so much.
Yeah.
Well, if we don't have any other questions, then I'll let you go ahead and have the rest of your night. So
Great.
again, if you need my information or need to contact us, the best email is info@mgakc.org. You can shoot us any questions that you have follow-up and you'll get that brief survey. So thank you so much and have a great night.
Thank you, everyone.
Bye.
Bye.